I want to thank the organizing committee, especially Professor Ahmed Shawqi, for the kind invitation. This is my agenda for the coming minutes. As all we know, major progress has been made in the field of liver transplantation since the first procedure was performed by Professor Tom Starzl, as Professor Refaie mentioned. And despite of these improvements, renal dysfunction before and after transplantation remains the major complicating factor associated with increased health care costs, morbidity, and mortality. Creatinine-based estimates of the renal function is inaccurate in the setting of end-stage liver disease and often lead to underdiagnosis and late intervention. It is very important to understand the etiology and the stage of dysfunction, especially when we are considering simultaneous liver and kidney transplantation. Here we can see that there is excellent short-term but a very poor long-term graft survival after liver transplantation. And this is, of course, because we faced another part of the story, which is the complications of immunosuppressive drugs. Of course, the unmet needs following liver transplantation are divided into two major categories. First, the recurrence of the primary disease and the immunosuppression-related problems. Regarding the primary disease, now I believe it's about to vanish because we have the new drugs treating the HCV, especially these are the major cause of transplantation in our patients. And now for the complication of immunosuppression drugs, we have the major problem, which is the renal impairment. It is very important to know the staging of chronic kidney disease and to estimate this dysfunction with the GFR to know the damage of the kidney. This was a very big study done to see the renal dysfunction in Europe, and as we can see that the percentage of patients with decreased GFR increased by time when we compared 1 month after transplantation with 5 years after transplantation. Regarding renal impairment, we have risk factors. We have pre-transplant renal pathology. The HCV itself is a risk factor, diabetes mellitus, and most of our patients are diabetics. And then we have the major risk factor, which is the CNI. The CNI can cause renal affection either acute by decreasing the GFR, by causing afferent arteriolar vasoconstriction, and then it becomes chronic when there is irreversible structural damage done due to long-standing hypoxia secondary to the vasoconstriction. Here we can see that immunosuppressive therapy with CNI is the major cause of renal dysfunction post-liver transplantation, compared with other causes. This study showed that up to 60% of the long-term liver transplant survivors will develop chronic kidney disease, and around 20% of these patients undergoing liver transplantation will develop stage 4 to 5 chronic kidney disease by 5 years. And we can see here that this is very common among liver transplant recipients compared to other organ transplant recipients. And of course, the risk of chronic kidney disease increases by time, and it is higher in patients with higher MET scores. Patients with renal dysfunction 9 months after transplantation have a 16-fold increased risk of developing permanent renal dysfunction, and a decrease in the post-liver GFR over time is a very strong predictor of patient mortality, as we can see here in this graph. This was a study done, and this study concluded that administration of the lowest effective dose of tacrolimus and adoption of strategies to spare the renal function are very important measures to reduce the risk of late chronic disease and the deaths post-liver transplantation, especially in high-risk patients. And this is very important because in the very early stages, always the intensivists and the hepatologists, they are afraid of rejection and they give high doses of immunosuppression, and this affects the survival on the long term. So the choice of protocol and treatment is very important. We should consider the HCV status of the patient, the HCC, the renal impairment, the autoimmune, in pediatric age group, how to tailor and to be flexible, and of course the financial resources of the patient. So we consider all this when we choose our protocol. So the goal is to find the right balance in immunosuppression. We don't like to give too much immunosuppression so that the patient will be over immunosuppressed, and then we face the infection, renal impairment, and recurrent HCC, and also not to be under immunosuppressed so that we will not have rejection. Protecting renal function requires a multifactorial approach. We use the biological agent to use induction to postpone the CNI, like the basiliximab. We use minimal doses of CNI, and of course we have replacement options like MMF and MPA. And the everolimus, I believe, the mTORs, I think, is a real milestone in transplantation because it spares the kidney. The H234 trial is a very important trial. It's the largest liver transplant study conducted to date, and it showed the everolimus with induced tacrolimus improved the renal function in de novo liver transplant recipients. This was a study design. There was an arm with tacrolimus, and the other arm was, after 1 month, low-dose tacrolimus with everolimus. And in this study, it reflected the typical transplant population because they have HCD patients, alcoholic patients, HCC, and other indications. Here, they compared the biopsy-proven acute rejection in the two arms, and as we can see, it was less in the arm of everolimus and tacrolimus. After 12 months, it showed improvement in the renal function with everolimus plus low tacrolimus, and this improvement, it was after 1 month and it was sustained for 1 year. Also after 24 months, it continued to be sustained, and the improvement was very significant after 1 month of the introducing the everolimus. Regarding the adverse events, the only significant difference was the hyperlipidemia, the neutropenia, and lower limb edema. Here in this study, it showed that the arm of the everolimus and tacrolimus, they have proteinuria, but it was less than 300 milligram. So introduction of everolimus with reduced exposure to tacrolimus at 1 month after transplantation achieved a very good preservation of the renal function at 2 years post-transplant with no compromise in the efficacy. I will rapidly speak about our experience. We have started our first transplantation in Wadi Nil Hospital in 2001, followed by Egypt Air 2007, and then Ain Shams University 2008. And by now we have done more than 1,000 living donor liver transplant recipients. This group of our patients, we have HCV, cryptogenic hepatitis B, Budd-Chiari, alcoholic fulminant. We have done abdominal liver transplant from familial hypercholesterolemia to HCV end stage. Of course, liver and kidney for end-stage liver disease. So for the renal impairment, more than 40% of the patients had renal impairment. We adopted the renal sparing strategy. We used induction by basiliximab. We always use CNI minimization and introducing MPA and MMF. Early introduction of mTORs was very beneficial in these patients. 80% of our cases were controlled immediately after transplantation and after shifting to the everolimus and maintained adequate renal function. Only 5 cases progressed to end-stage kidney disease and needed transplantation. Chronic kidney disease was less than reported cases in the literature in our center, and I believe this is because of minimization and proper choosing of the patient. The first month's trough level of CNI was a very important predictor. Still, the proteinuria is our main obstacle to put the patient on mTORs. We have some patients on MMF and MPA monotherapy, but this is an off-label protocol. In summary, liver transplantation has progressed to become an established solution with excellent long-term outcomes. This was not achievable without multidisciplinary team. Complications are common, and if left untreated, it would lead to graft failure. Acute rejection is overestimated. Close follow-up is very important to pick the proper time for manipulating and shifting strategies. Minimization of immunosuppression may present a valid alternative that permits to reduce long-term complications. Induction therapy is beneficial for patients with renal impairment on time of transplantation. Renal sparing strategies is associated with risk reduction of chronic kidney disease, preserving the renal function. Finally, I would like also to conclude with this quote. After all these complications, still the worst complication of liver transplantation is to die before receiving the transplant. Thank you.
Thank you, Professor Rasha. It's an excellent presentation. Any comments or questions? Okay, Dr. Rasha, how frequent you do renal transplantation and liver transplantation? You find it an indication in some cases?
Excuse me, the question again?
When you do renal and liver transplantation at the same time?
You mean in the same session? Actually, we don't do in the same session except in pediatric age group, because it is very difficult in the adult to know if this kidney is really in failure or not, because sometimes after liver transplantation the kidney improves. So in most of our cases we have the liver transplantation first, and then after that we can do the kidney, because sometimes the kidney improves after the liver.
What is it, Fed?
Well, so, it's obviously a very good point, because they're all living donors. So you have to calculate the risk from a living donor, especially when it comes to a kidney. We use a 30-day guideline. So if you're on dialysis, not with renal insufficiency, before you get your liver transplant, then you are also placed on the kidney transplant waitlist, and you get a combined liver kidney transplant. We know that the mortality of patients that remain on dialysis after liver transplantation is much higher than if you're getting organs. Now, in terms of the practice of kidney transplantation with liver, we've seen a dramatic increase over the last 5 years or so because of the higher acuity and the longer wait times. Some centers adopt about a 6-week wait time so that you can, enlist the patient for liver kidney. The interesting thing about this, however, which we are learning, is that it is probably not a good idea to do a liver and a kidney transplant on somebody who's sick. And by sick, I mean a male of 35 or higher. Why? Because in a significant majority of those cases, the kidney does not work. And why? Because the kidney is a delicate organ. It likes a happy environment. And when the patient is sick, they're coming out of the operating room on 2, 3, or 4 pressors. Sometimes the kidney transplant actual operation needs to get delayed for 12 hours or 24 hours because the patient's unstable. So the cold ischemia time goes up. Then the patient is sick in the ICU for a while. So now you've got a liver kidney transplant and the patient's still on dialysis. So we've seen that if you're going to do a liver kidney, they're best done in patients that are actually not as sick. And actually on a national level in the United States, what is going to happen is we're going to prioritize patients for a kidney transplant after a liver, so that the patient gets the liver transplant, physiologically gets better, and then a week or 2 later, they're still very high on the wait list, and then they can get the kidney. Now, you'll lose the immunologic advantage of getting the kidney and the liver from the same donor, which reduces the incidence of rejection of the kidney, but it's still much more worth it, because you're going to have a working kidney at the end of the day. So I think there's no question that, if you know the patient's going to stay on dialysis, you need to devise a way to get them a kidney. The question as the patients get sicker is the timing, because the kidneys don't like a very stressful environment. No question.
And also, I think it's also, there is a problem with fluid management after the transplantation.
Most definitely.
Yes, because in liver we don't like too much fluid.
Correct.
For the congestion, and in the liver,
correct.
the kidney they like to push. So it's a problem after transplantation.
The other comment I'll make is pertaining to your renal sparing protocol. I think that's a very, very good point. And I think this is the first time in the history of liver transplantation that we're able to modify immunosuppression and sort of customize the recipient, because we have the mTORs. And when people talk about mTORs, they say, well, is it good for the kidney? No, the mTOR is not good for the kidney. The only thing the mTOR allows you to do is not use so much calcineurin. That's it. That's the benefit of it. But I think there's no question that as you're able to cut down on the calcineurins with the use of mTORs, it'll reduce long-term morbidity and renal insufficiency.
Yes.
Thank you very much, Dr. Rasha.
Thank you.
Move to the last speaker of this session, Dr. Rafi Kapoor Shar, one of the youngest